Good aft Good afternoon, everyone. We have a lot of people in the waiting room joining us, so I will just let everyone trickle in before I get started here in a second. Feel free to also let us know where you're joining from, whether you're a clinician or a caregiver. We always like to know that. All right. I'll go ahead and get started. I'm Ruthie Marker. I am the Education Program Manager at the Allergy and Asthma Network. I'm delighted to welcome you to this afternoon's CME accredited webinar. We have a special presentation today focused on antihistamines, biologics, and BTK inhibitors. Before we get started today, I'll just go over a couple of housekeeping details. First, everyone will remain on mute during the webinar to minimize any distractions. We will record the session today in its entirety and upload it to our website in a few days. You can watch all of our previous recordings on our website, any previous webinars from this year and last at allergyasthmanetwork.org under the events and look at free webinars. Our webinar schedule today is scheduled to last 1 hour, and that will include time for question and answers session after the presentation. You can send any questions throughout the presentation in our Q&A box located at the bottom of your screen. We also have a team member that will be checking the chat. If you have any questions or need any technical support or help, we'll try to answer all the questions before we finish today's webinar. This Advances webinar is brought to you in collaboration with the American College of Allergy, Asthma, and Immunology. The college offers CME credits for physicians and attendance credits for all others. You can create a free ACAAI account and earn CME credits for this Advances webinar through their member portal. All attendees will receive a certificate of attendance. Please note that no additional continuing education credits will be provided. A few days after the webinar, you will receive an email from Zoom with supplemental resources related to today's webinar, as well as a link to download that certificate of attendance. Please feel free to drop any concerns you have into the chat. Today's presentation is titled Chronic Urticaria, Antihistamines, Biologics, and BTK Inhibitors. Chronic urticaria remains a complex condition that often requires a stepwise, individualized approach to treatment, along with staying current on emerging therapies. In today's webinar, we'll explore practical strategies to improve symptom control and enhance patient outcomes. Joining us today is Dr. Clinton Dunn, a full-time allergy and immunology clinician serving the Norfolk and Hampton Roads area as part of the Children's Specialty Group affiliated with Children's Hospital of the King's Daughters. He is also an assistant professor with Mason and Joan Brock, Virginia Health Science at Old Dominion University. Dr. Dunn has clinical interest in allergy, skin disease, asthma, pediatric anaphylaxis, inborn errors of immunity, and primary immunity regulatory disorders. He is also actively involved in teaching medical students and residents with an emphasis on evidence-based, cost-effective care. With that, I will hand it over to you, Dr. Dunn. Thank you for being here with us today.
Thank you for having me. So we're going to get started. So I am a clinician, so I am going to keep this pertinent to families or individuals that are suffering with urticaria, as well as providers, so that we can try to walk through all of this. Neither myself nor Ruthie nor our support staff have any disclosures related to everything. Our objectives today are that we are going to try to learn about urticaria, about subtypes, and applying what we know about urticaria to actually help make better life, quality of life emphasis for families and for patients to set us up for success. So I always want to start at the basics. So whenever I'm working with any trainee, I always start with what are the basics of everything. And so with urticaria, we always start with our nomenclature about timing. So we have acute versus chronic urticaria. Acute urticaria is wheals or angioedema that lasts less than 6 weeks. Chronic is greater than 6 weeks. And that's typically continuous 6 weeks. So it's not intermittent during that time. It's most days of the week. during those times. And I apologize, whenever I use the term wheal, we're talking about an area in the epidermis where there's actual swelling and associated erythema, where they have that classic description of wheal or flare. It kind of looks like a fried egg that sits on the skin, where you have that raised area, that redness spreads throughout. And then angioedema is deeper swelling. So it's underneath the epidermis in that dermis or subcutis. Typically, there's more itch related to the urticaria, the wheals, whereas angioedema has more tightness or kind of tingling aspect rather than anything else. And we are focusing today for urticaria and angioedema on histamine-driven symptoms. There is another etiology for angioedema that is driven through a separate process called bradykinin that I'm not going to be adequately able to cover the subject matter. I'm mainly going to be talking about chronic urticaria. Chronic urticaria is the big umbrella term. And when we talk about chronic urticaria, there are subtypes, and we'll even talk about what are called endotypes in a second. So the subtypes for chronic urticaria, we really break them down into chronic spontaneous urticaria, that's sometimes called CSU. So if you see me throughout this talk talking about CSU, it is chronic spontaneous, which means it comes out of nowhere, or it doesn't really have a preceding exposure that we think about, and it has gone on for greater than 6 weeks. And then CINDU, or chronic inducible urticaria, is a different subtype. So chronic spontaneous comes out of nowhere with no provoking, whereas inducible, we do something to provoke it. And that could be because of dermatographia, which in Latin means skin writing, or kind of scratching of the skin, pressure, heat, temperature, sun, water, or even kind of our internal core body temperature. There was a really couple of good reviews that I'm always going to point back to whenever we think about it. So the thing on the left comes from our updated Urticaria International Guidelines. And then about a year ago, there was a big paper that looked at the subtypes of cold-induced urticaria, because for so long, clinicians just called it cold-induced urticaria, but cold-induced urticaria can have a lot of different modifiers or cofactors, where you can have overlap, where you can have cold-induced dermatographism. So there's a lot more overlap in the chronic inducible urticaria. Most of our therapies right now are focused on chronic spontaneous urticaria. Every time we talk about a disease state, we need to think about the epidemiology of the disease. So chronic spontaneous urticaria, or CSU, affects around 1% of the population, whereas CINDU affects about 0.5% of the population. It's estimated that there's 3 million individuals inside the United States that have chronic spontaneous urticaria, which is a large amount. CSU is predominantly female, predominantly older, and most patients with CSU are really bothered and have symptoms that last for a long time, with about 1 in 5 having symptoms more than 5 years. And so it really can be a huge burden that we actually have to think about. Whereas with inducible urticaria, there's overlap with people who have inducible urticaria also having spontaneous. They tend to, though, be younger. They tend to be our adolescents or young kids, but they're a little bit more symptomatic for longer durations. And so they tend to be people that will have episodes where they will go into remission, but it will relapse, and it will actually can last much, much longer in their lifetime. So why the lecture, right? So Ruthie kind of hinted about it, but urticaria is one of the most bothersome allergic skin conditions, and even skin conditions in general. So our colleagues with dermatology talk about the Dermatology Life Quality Index, which is a marker for how much our life is impacted outside of just clinical visits, looking at sleep, at daily function, at ability to socialize, go to work, absenteeism, our internal self-perception. And we do know that chronic urticaria actually has a higher impact on quality of life than atopic dermatitis, than psoriasis, and it correlates really highly with mental health disorders, including depression and anxiety, and people that don't feel heard or appreciated, and they actually have to remove themselves from a lot of their life, kind of what they enjoy to do. And that correlates really nicely with elevations in our urticaria activity score. So I'll talk about what the urticaria activity score is a little bit later, but people that have higher urticaria activity score actually tend to utilize healthcare more, have more hospital visits, doctor's visits, require more medications. And this is a population that we can really intervene on and help with. And actually tracking using standardized questionnaires can actually set us up to make sure that we are identifying and treating them appropriately on who needs systemic therapies, and it can actually be cost effective. One of the biggest changes in the last couple of years is something that came out about endotypes of chronic spontaneous urticaria. So we've known about in asthma, and for those of us that are not clinicians, the concept behind endotypes is that there's an underlying mechanism inside our body that drives the process that we see externally. And so with asthma, we've really done a good job of defining endotypes, and we're starting to look at other disease states like food allergy and chronic spontaneous urticaria for what are called endotypes. And we've realized two major endotypes that we've started to see, and we've identified them as what's called type 1 and then type 2b. Type 1 is when we make IgE or allergy antibody that attacks our self antigen. So it's called autoallergy, where you're actually making allergy antibody that attacks our normal tissue, like thyroid tissue or other presentations that we naturally see in the proteins that circulate, and that it activates our allergy cells because we actually make those auto antibodies instead of anything else. And then type 2b is when we make an IgG or a different antibody that attacks our allergy cells. And so that's actually IgG directed to our Fc epsilon R1 or to IgE itself that then activates mast cells through that signaling of IgE to Fc epsilon R1, which is an important thing because we focused our therapies mainly on that direct pathophysiology or that pathway looking at mast cells. Now, when we talk about it, it also helps explain why some patients respond to certain medications. But I will point out, whenever we started to talk about endotypes, we realized this non-typable cohort. And there was a lot of overlap between the type 1 and the type 2b, where about 89% of patients with type 2b actually also had type 1, and about 41%, which also correlates with some of our non-responders, actually have non-typable endotypes. So we still need a lot of work to go. And for the longest time, one of the biggest things that we always said was routine labs are not cost effective, and they actually did not change the clinical outcomes. I think this is going to be changing based off of what our new therapies are. And I do think that it's going to help guide us with everything. But the most important thing that we can think about when we're talking about chronic spontaneous urticaria is the history and the physical that we get. And so every visit with chronic urticaria, whenever I see a patient in my clinic, I am always thinking through the C's. So I always make sure that I'm confirming the diagnosis. Many, many times people come in with a diagnosis of chronic urticaria, and what they're describing actually may not be urticaria. And so we have and live in an age where we have enough technology. We can actually get pictures and have patients bring it in so you can see what they're living with. And actually, I encourage all my urticaria patients to take as many pictures so I can see what they're struggling with to try to help set them up for success. Looking at other causes as far as trying to make sure that we do fit them into an endotype box if they do fit, but also determining cofactors, so those inducible urticarias and comorbidities that we actually want to think about, including assessing mental health, which I acknowledge that in a busy allergy clinic, as a clinician, I struggle with how we need to grapple with the mental health implications on our patients with chronic urticaria. And I think that it's important to then always circle back every single time to what is the activity, how much is it impacting, and how we can try to help control them, either escalating up or de-escalating when those choices are available. For all of our trainees out there, I do think we need to make sure we put an emphasis on the differential for chronic urticaria. So even though we constantly will say, hey, this patient has urticaria, sometimes we don't have a tendency to revisit those patients and say, is that still correct? And so going back to confirming the diagnosis every single time, I always harp on the red flag symptoms. So what I focus on whenever I am confirming is not just looking at pictures, but making sure that we're not missing something that's underlying that's worse. So especially making sure that we're not having hives that stay in one location for greater than 24 hours, that are not leaving marks, that we don't have skin changes or scarring, and we don't have systemic symptoms. And by that, I mean weight loss, chills, night sweats, fevers, because really we need to be making sure that we're not missing other etiologies. And the differential is there on the left, including urticaria vasculitis, looking at our cryopyrin symptoms, our Schnitzler's syndromes, Gleiss syndrome, which is kind of an eosinophilia associated with angioedema. And so making sure that if we have urticaria with angioedema, that's a different process than angioedema alone. Or if we're having more of those chronic changes, saying, hey, do we need to get skin biopsies? Are we having blistering or peeling, or making sure that we're not missing just something while we are trying to treat that? And I've actually been more successful whenever I try to keep that broadened thought, even if it's my patient that's had urticaria for years. It does make sure that we don't miss anything. The most recent guidelines that kind of came out from an international side about 2 months ago did start to put more of an emphasis on labs. And so for the first time, we're starting to see a little bit more recommendation for us to get complete blood counts, to get anti-thyroperoxidase testing, and total IgE. And so now there is some recommendation that, at least on the initial question, that those may be utilized. There is some mention on CRP and ESR for inflammatory markers. Those ones are a little bit more debated, and those are usually guided more by history, where we actually try to think about it. For the inducible urticaria, we do talk about some of the specialized testing, and I would work with a board-certified allergist to make sure that we are appropriately doing testing that would be indicated in that situation, because we do want to make sure, if they have inducible urticaria, that we see how they're provoked and how we can help mitigate some of those cofactors with everything. So the whole point of this talk really was to focus on the antihistamines, the biologics, and the BTK inhibitors. And so I am going to transition from understanding the background of what we need to do from a basics standpoint to actually saying, hey, let's dive in and actually start to treat this. And so our guidelines really have been doing a good job of being updated. And after patients fail therapies, we really are now actually in an exciting time where we have systemic therapies. For the longest time, we had to use immunosuppression, we had to use cyclosporin, and I've used those in my career, and I do think that there's a utility to them. I do think that now we have a lot of better, safer options that we can talk through. And so now our guidelines do mention 3 systemic therapies that we are going to dive in on. But first, we need to make sure we talk about antihistamines. And so in general, by the time that they come to see me in an allergy clinic, the thing about antihistamines is we treat to the symptoms that they have. Most people start the standard dosing, which is the FDA kind of the package label recommendation. We tend to prefer second generation antihistamines. So your cetirizine, your fexofenadine, your levocetirizine, your loratadine, desloratadine. Outside the United States, they do have Avastin, bilastine, and rupatadine. Whenever we start a therapy, we start the lowest dose and we titrate up or down to try to make sure that we don't over medicate, and we try not to make sure that we run into side effects. But most patients, for the longest time, I always said, and I'll show you in a second about some of the literature on how many patients actually respond to antihistamines. We try to find the most minimal amount of medicines that we want to use. And if we do have unresponsive patients, you can titrate up the dose. And the guidelines do talk about step therapy of most of the time, by the time they're seen in an allergy clinic, we've already had them on standard dosing. But you can increase the dose in the skin for skin conditions up to 4 times the approved dose. But we should be monitoring for side effects. Most common side effects in different populations are going to be sedation or somnolence or cholinergic or anticholinergic side effects. They're something that we see often. There is some literature on adding other either histamine blockades or leukotrienes, probably more evidence for the leukotriene receptor antagonists like montelukast for refractory therapy. I do like, I'll give little plugs along the way for some good resources. There was a paper out of South America which actually looked at a prognostic calculator to say, hey, who or which of my patients are going to be the ones that respond to antihistamines. And it was different in each culture, but it really did set them up to actually help the clinicians kind of predict it. And I don't know if the QR code is going to pop in there, but there is a QR code in the middle, so you can actually look at that paper and actually use the calculator with them. And these slides will be available. But I think probably one of the biggest things that I struggled with whenever we were talking about this presentation is the difference between providers and patients. And I thought for the longest time that I really understood my patients and I really had a better sense of what they were going through. And then the Voices study came out, and it looked at the real world data on patient perspectives versus physician perspectives. Now, the numbers weren't gigantic, but they showed a common thread where, number one, our patients are cycling their antihistamines, which we see not infrequently reported to us in patients who have allergic rhinitis. But whenever we talked about them, if they weren't controlled and we did step them up, a lot of providers actually had a much higher assumption that they were responding to those therapies. But only about 1 in 4 patients, which is lower than what we classically tell ourselves were responders or complete responders to antihistamines. About 75% either were partial or completely non-responders. And that was in patients who truly did have a diagnosis of chronic spontaneous urticaria. And it told us that we shouldn't just go under our assumptions. And then whenever we actually look at everything, there was a survey separately from Giselle Mosnaim, and what she looked at is the difference between how much we had control with patients versus with physicians. And physicians by far and away reported less symptomatology in our patients and better control than patients reported. So patients reported about 20 percentage points higher symptomatology than providers, even whenever they were not on medications, even when they were on medications. And that wasn't specialist specific. It wasn't just allergists doing it. That was dermatologists, that was primary care doctors, and it said that we have some room to get better. And that patients with antihistamines, while we assume that they're going to respond, sometimes we need to have more frequent visits and checking in to make sure that we don't miss it. And then also make sure that we do assess a lot of their chronic spontaneous urticaria comorbidities, including some of the mental health aspects, because there actually was a much higher rates of anxiety and depression than we realized. So for our systemic therapies, we have 3 FDA-approved systemic therapies. And I think that understanding the mechanism and kind of where in the process of mast cell degranulation do we actually think about it. So the first therapy that came out was called omalizumab. So omalizumab is a humanized antibody that targets to IgE. The challenge with that mechanism is when we've had other agents, including a medicine called ledulizumab, which has a higher affinity for IgE, we realize that the mechanism is not entirely driven through IgE binding. It's probably more multifactorial of omalizumab affecting downregulation of the allergy antibody receptor on mast cells and basophils. It actually trapped autoantibodies that were forming, and it actually affected the bound IgE on B cells. Dupilumab, which has been widely utilized in a number of allergic diseases, is an agent that started to come over the last year that affects that skewing towards allergy cells. So it tends to work not in the mast cell, but actually works on the T cells and the B cells to make sure that we're not skewing towards making more IgE or even affecting class switching of our antibodies at our B cell level, which makes sense why it takes the time that it does, and also may be a better option for some of our non-responders for omalizumab, but also our patients that maybe have type 2B endotypes. And then remibrutinib is the newest kid on the block. So remibrutinib is an oral agent. So it's an oral BTK inhibitor. And we're going to talk about BTK inhibition in a second, because I think that it's something that as allergists, we are trained that BTK equals a very specific disease that we see in young males at a young age, which is called X-linked agammaglobulinemia. But our colleagues with hematology and oncology have been using BTK inhibitors more widespread than we have, and actually having a very specific BTK inhibition will affect our intracellular signaling through our Fc epsilon R1 receptor, and actually have a little bit of better protection directly underneath our allergy receptors. So like I had said, omalizumab was the first biologic that came out. So it specifically works directly on kind of that first step of mast cell activation. It is approved 12 years and above. There are two doses if you look at the package insert. So there's low dose and then there's standard dose. I confess I don't often use the low dose. I tend to prefer the standard dose, which is 300 milligrams every 4 weeks. It is a fixed dose, so it is something that does set us up as compared to our patients with allergic asthma or our patients with food allergy. Now, there is good literature that looks at non-responders or partial responders with options to titrate that dose either up in dose, so going from 300 milligrams to 450 or 600, or to an increased or shortened interval, or doing both. That does it's a little bit harder to get it approved in that way, and there is some work that can be done, but it does work as far as those dose escalations. And it is approved for allergic asthma, chronic rhinosinusitis with nasal polyposis, and IG-mediated food allergy. Omalizumab is a great medicine, and then the newer kids that are starting to come out is dupilumab, and then I'll talk about the other agent. Dupilumab was approved for CSU in 2025, but it's been around since 2016 for other indications, including asthma and more recently, asthma and atopic dermatitis were probably one of the first ones, but then CRS, or chronic rhinosinusitis with nasal polyposis, and eosinophilic esophagitis, and pemphigoid and prurigo nodularis, and more recently with allergic fungal rhinosinusitis. In CSU, it's the same as the adult dose that we typically think about. So it is a pre-filled pen or syringe. It's a 600 milligram loading dose and then a 300 milligram every 2 weeks. It's approved 12 and above for people who have chronic spontaneous urticaria. Remibrutinib is the other one. And so if you've gone to any of our annual conferences, I feel like it's the signs are everywhere for remibrutinib right now. It is the only one that's 18 and above. So the other ones are 12 and above. This one is 18 and above. It is an oral agent that is done as 25 milligrams twice a day. It does not have any other current clinical indications. And it is metabolized through our cytochrome P450, 3A4 enzyme. And the reason that it's important to bring that up is that's the same enzyme that also metabolizes cyclosporin. It also metabolizes the antifungals and the statins and the calcium channel blockers and certain antidepressants. And so in your patient that has CSU that's also on cyclosporin, we may have to talk about dose adjustments. If they're also on antidepressants because of comorbid mental health conditions, we may need to talk about how we make adjustments to dose to make sure that we don't run into super therapeutic levels and affect everything. So before I talk about efficacy, I want to make sure I talk through the scoring system. So the scoring systems that are utilized are either the UAS or the Urticaria Activity Score. Urticaria Activity Score, you have a score for how many wheals or hives they're having and how much itching they're having. And a patient looks over the last week and they actually kind of self-assess from mild to severe or none to severe. And you get a score for each of those from 0 to 3. And then you do that for each day and you track it. And then for the urticaria control test, that one's a little bit different. So that's 4 questions that you go on. And so Urticaria Activity Score, the UAS, high scores are bad. That tells you that you have a lot of disease that's ongoing. The UCT, or the Urticaria Control Test, the lower the number is, the less control. So 16 for UCT is good. For anything less than that, we kind of walk down. And that's typically the one that I use most often clinically. Clinical trials are going to reference the UAS because that's going to be a little bit more informational as far as on a daily basis. And there is the angioedema activity score looking at swelling. And so I'll reference some of that in a second. But if you're not using it, another quick plug is for the Cruise app. So there's an app that helps patients track their symptoms, and that's the QR code on the right. It actually helps give you their UAS over the last week. I do encourage my patients with urticaria to actually download that so that they can then help me know how symptomatic they are, so we can actually make sure that we are coming at them with evidence to guide their therapy. And I do like that. It comes in many different languages, so you actually can tailor it to your patients, no matter whether they're inside North America or outside. So knowing that as far as how we define effectiveness, we focus on the UAS. And so UAS or UAS 7, so the Urticaria Activity Score 7, so urticaria activity over the last 7 days, Complete control is talked about as terms of 0, well-controlled is less than 6. And so omalizumab, their trials, which were called Asteria 1 and 2 and Glacial, all the way back in 2015, really showed about a third of patients will have a complete response, which is different than how many patients have type 1 or type 2B, but about 65% maximally will actually develop well-controlled UAS within 12 weeks. But after we stopped it, the symptoms came back. And that's something that we really haven't gotten into disease modification yet. As we've been using omalizumab widely clinically, we've been trying to figure out why there are some non-responders, why there are some people that are partial responders. And so not in the clinical trials, but after the clinical trials, we started to look at it because we know that certain markers are predictors for prolonged chronic urticaria, but we really didn't have a good way of identifying what were non-responders for medicines. And so in retrospective grouping, we found some biomarkers that may have some indicators for lack of response. And it's the combination together of a low IG, which is defined as less than 40, a positive CU index. So CU index looks for type 2B CSU, or kind of that IgG targeting IgE or IgG targeting Fc epsilon R1 at the mast cell level. So saying, hey, this is something that's not going to be helpful by an anti-IgE. And then basopenia, which we've known about as a predictor for prolonged urticaria symptoms, but they actually defined it as a low blood histamine content. You can get an IgE in most available labs, and you can get a CU index now in some of our larger commercial labs as well. Subsequently, there's been some literature looking at the degree of positivity for the thyroperoxidase IgG level, and the higher that it is, the more likely they may not be responders, which kind of goes along with their skewing not towards a higher IgE level, but towards a lower IgE level, and they're more that autoimmune phenotype. And previously, there was a lot of looking at positive autologous serum skin testing, where you actually take the patient's serum, you spin it out to isolate the serum, and then you actually skin test with it. And that really did correlate nicely with that type 2B or that non-typeable or non-type 1, non-type 2 population. And then dupilumab, whenever they did their trials were called Cupid, so Cupid A, B, and C, and they took systemic therapy naive patients. So they took patients that had never been on a systemic therapy, and they started on it. And so with dupilumab's mechanism of action, where it targets those T cells and those B cells that then skew towards making IgE, it took longer to have an impact on the mast cell, on actually affecting Ig production. And so while omalizumab started in 12 weeks, dupilumab didn't start working until 24 weeks. And it had a higher effect in patients who were omalizumab naive that were biomarker agnostic. They didn't have any specific biomarker that actually had to predict whether they were going to respond whenever they look back. And about 3 out of 10 people will have complete response, and about 40% will be well controlled. So a little bit on the lower side. And for our non-responders to omalizumab, even though dupilumab was biomarker agnostic, they didn't have the biggest effect in that group. It was only kind of more mild. And so I really want to show you that if you're going to commit to dupilumab, and we're going to talk about the time to expectations, that one took a little longer. Now, it did catch right underneath half of the patients, but it did work well in the right grouping, but it may be something that we need to make sure that we're treating their other comorbidities with that. And then the newest kid on the block, which is the remibrutinibs, their trials are called REMIX, and REMIX 1 and 2. And they had around the same levels, right, around 30 to or 20 to 32% UAS completely zero, so completely responding by 12 weeks. But the interesting thing, because of the mechanism of action, because it was an intracellular agent that could start working fast, and you really started to reach steady state much quicker, the initial response was noticed in the first 1 to 2 weeks, where about a third of patients can come back within 1 to 2 weeks and be like, yes, I am a responder. And you actually had separation from placebo even as early as 1 week. About 50% of patients were well controlled, and they had sustained efficacy, just like all of the other therapies, while they were on therapies. In the remibrutinib group, similar to dupilumab, it was regardless of their IgE, their CU index, their basophil level, or prior treatments. And so it really became an interesting question of which one is going to be the right therapy. And so I think I like to see things next to each other. But I think that it's hard because we show different pictures with that. And we show that, hey, they all respond, but we don't have as much guidance on which one is the quote unquote right therapy. And so whenever you look at it, not everyone responds to it. And not everyone that didn't respond to one therapy will respond to another. And so I think that it's a big question. And I'll talk about head-to-head studies in a second because there's not much. And I think that treating comorbidities, since we know that 30% of patients with chronic spontaneous urticaria do have inducible urticaria, and we do know that angioedema is seen at a high rate in patients either in isolation or with their urticaria, we realize that looking at what's called the mean difference, or kind of the change in comparison for angioedema compared to placebo, omalizumab and omalizumab and remibrutinib both had a reduction in angioedema activity, and remibrutinib may have had a little bit higher reduction in their angioedema activity score, about 15% compared to 8%. So it may be some of the choices that we kind of say, hey, what is your major symptom? Are we having angioedema? And there is probably more data on omalizumab in the chronic inducible urticaria population. So if you do have that patient that has, comorbid chronic inducible urticaria, they may tend to do better on omalizumab, where whenever they've actually looked at real world data through the UCARE network, they actually showed, typically, remember, chronic inducible urticaria are younger, but typically treating them with omalizumab while they're younger, you actually could get away with getting them off of things where they may have gone into remission. Now, they didn't follow them and say how many people relapsed or anything like that, but the younger patients may actually be able to induce remission for chronic inducible with chronic spontaneous overlap. And remibrutinib is being studied in chronic inducible urticaria, and I don't have a reason to suspect that it wouldn't work. Dupilumab, on the other hand, didn't include angioedema in their CSU trials, and it only had minimal efficacy in chronic inducible. So if you have that patient that has chronic inducible urticaria, then we may not want to pick dupilumab for everything. And so when we talk about head-to-head trials, this was a plot that Derek Chu out of McMaster's kind of put out whenever there was an update to some of the literature as far as how we're going to do a grade analysis. And the thick bars are how many trials in comparison. So whenever you see a placebo at the top and a bar going to that, they're comparing a double-blind placebo-controlled trial, which is really the gold standard. But you'll notice that there's only a couple of studies that compare to each other. So tezepelumab, which is an anti-TSLP, compared themselves to omalizumab, and ledolizumab, which is a stronger affinity IG, compared themselves to omalizumab, and neither reached it. And then we've looked at omalizumab compared to, or sorry, not omalizumab, we've looked at cyclosporin compared to other things, and we've looked at some novel agents compared to omalizumab, but really we do a better job of doing placebo to therapy, and we haven't done good high-quality evidence to compare them. So we're left sitting here and trying to do comparisons to the best of our ability. So in our grade analysis, we compared omalizumab high dose or standard dose, and then low dose, and then remibrutinib and dupilumab. And in general, if you have urticaria activity, we do know that there's probably higher or faster efficacy with omalizumab 300 and remibrutinib, and especially if there's angioedema, those two tend to be our preferred aspects, better than omalizumab low dose. And we don't know about dupilumab with angioedema. I think that's still something we are figuring out. The big question is going to be about safety. And then Giselle Mosniam's group, she did that comparison for mean difference, comparing the patients in the clinical trials compared to placebo. And it did look like that omalizumab had a little bit more of a reduction. Now, this was before the pooled analysis with Remix 1 and Remix 2, and remibrutinib did come down a little bit more whenever they did that analysis. That was published, unfortunately, after these slides were due. I always, whenever I commit to a systemic therapy, I want to set the standard. I want to set the expectation for patients that they're not going to call me the next day and say, hey, I didn't respond. I want to make sure that we set the expectation for how we're going to do it. And so for omalizumab and for remibrutinib, I say at least give me 3 months. At least give me 3 months. I think that usually you know earlier, both for omalizumab and remibrutinib. Remibrutinib, you can know in the first 1 to 2 weeks. Omalizumab, for the complete responders, you really do know by 12 weeks. And sometimes they're a little bit sooner by 4 to 8 weeks. But even the partial responders, we can actually have some signals that they're going to improve, but they have washout during the last week. For dupilumab, you really do need to set the expectation that it's going to be 24 weeks. And I typically, I'll show you how I kind of approach kind of a patient with CSU at the end of how I think about going them. Let's talk about adverse events, because I think that's going to be the big question. So omalizumab has a black box warning. Its black box warning is for risk for anaphylaxis. It's a rate of around 0.1 to 0.2. Whenever you looked at meta-analysis, it typically occurred within about 60% occurred within 2 hours of the first 3 doses. That's why the recommendation is to watch for the first 3 doses for 2 hours. The interesting thing, that was in the asthma studies that we noticed, and it was in post-marketing analysis with the chronic spontaneous urticaria studies, but it wasn't really noticed in the food allergy studies. And now that we're getting more data on it with food allergies, I do think it's going to be a question that we need to revisit as far as what is the true rate for everything. And I don't think that we fully know, but it tended to be in people that have a history of anaphylaxis. Dupilumab safety data was pretty similar to what we see in the atopic dermatitis literature, where it's an injection site, or there is some ocular surface disease and some facial dermatitis, and some arthralgias were starting to be reported more so in our adults, which we're starting to see more often with eczema. I'm going to give a kind of a whole slide to the BTK inhibitors because I think that that's the big question, right? So I talked about BTK deletions when we're talking about XLA. And so I think that blockade of BTK is going to be something that is scary to people. And so when we looked at remibrutinib's, or whenever I look through the clinical trials at remibrutinib's data as a clinician, the things that stuck out to me were normal things that can occur to people: upper respiratory tract infections, headaches. The BTK stuck out because it was a higher rate. So it's important to remember BTK as a protein is present in platelets. It's present in platelets. And we do know that whenever they saw them in the clinical trials, and my patients that are on BTK inhibitors are on remibrutinib, it was an incidental finding. It was, oh, they're there, but they actually didn't have to be treated. They didn't have thrombocytopenia. They didn't have true blood loss. They were noticed to have it. And it actually was self-limiting. They didn't have to treat it. It does raise the questions, especially in our adult patients that are going to get surgeries, is do we need to hold it? And there's no consensus on that one. That's a question that I'm asking myself is, as I'm treating somebody, is do I have to hit pause? I think the biggest question is going to be the immunologic consequences. In the phase 2 trials and in Remix 1 and Remix 2, in the phase 2 trials, they were doing dose finding. So they were doing, 25 milligrams, 50 milligrams, 100 milligrams. And at the 100 milligrams, which is 4 times the dose that we're using right now, over a year, there was no change to our immunoglobulins, to protection for titers, or to vaccines. And so the graph that you see there was actually what happened to patients, conglomerate of IgG, IgA, IgM, and Ig, and it didn't change, which is great. And that's what we want to hear and what we want to see. There's a poster that came out kind of right after this, which looked at vaccine response after exposure. So they actually took patients that were on 100 milligrams of remibrutinib twice a day, and they said, hey, you're going to continue it straight through versus you're going to pause for 21 days around the influenza and pneumococcal vaccine. So they're going to take it for 8 days. They're going to have a week washout, and then they're going to pause for 3 weeks. And then they checked titers 4 weeks later. And if you paused, you didn't have any effect on vaccines. But if you took it straight through, there was a reduction in response to hemagglutinin for influenza. And there wasn't as robust of a protection for pneumococcal. And I don't know if that has an impact. I think that it's important to say, as you're counseling patients, is that we know a lot, but there's some things we don't know yet. And I think that making sure that you're being completely transparent is that it may have something. And if we do have to vaccinate, maybe we need to pause so that we can make sure that we have an adequate response, especially to a vaccine that somebody needs. Now, the clinical outcomes for that, even though we talk about the vaccine titer data, I think it really does need to be replicated on a much larger scale and at the doses that we're going to use. Because remember, remibrutinib, the prescription dose right now is 25 milligrams twice a day. It is not the dose that they used in this poster. So how do I choose? So I counsel my patients starting at the top. I ask them, and I assess how much is bothering them, right? Do we want to pursue systemic therapies or do we not? What's their preference? Do they have a preference for injection versus oral? And what is our coverage for it? Because the best medicine in the world, if I can't get covered by our insurances, are really going to be a challenge. And if they have a strong feeling for injection versus oral, that's the first step. but also their age. I see kids and adults, and I see predominantly kids. But whenever I have somebody that is 18, right? Remibrutinib is only 18 above, and it's being studied younger. And I think that there's going to be some safety questions the younger that it goes, as far as what's safe, what's not safe. But if you have somebody who's 12 years and above, or if they're 18 and above, I think you have choices. For the first time in a long time, we have choices, which is a great thing. And so my patients, whenever I counsel them on omalizumab, I always think about it if they are the worried family, right? They want a larger body of evidence. They want and are willing to wait 12 weeks. They are okay with once a month injections. They also have comorbid chronic inducible urticaria or angioedema. And I am starting to check the IG and say, hey, are they elevated IG? Do they have a CU index? I go back and forth on the anti-thyroid peroxidase because I don't know what a low-lying titer really is going to do. But as we start to have better basophil testing, and as we have better kind of cutoffs for thyroid peroxidase, that may be something that helps guide us on that. And so I think that omalizumab has the biggest body of evidence. So that's really where I talk to them about. I use dupilumab in my patients that have other atopic comorbidities. So if they want to treat their asthma and their atopic dermatitis and their chronic rhinosinusitis, then I'm like, great. I think we have to prioritize one versus the other. And that's whenever I'm trying to say, what is our biggest symptom? So even though we know that chronic spontaneous urticaria has a lot of implications and impacts on quality of life, some patients don't feel it that way, and that's okay. And we have to go with what their major symptom is. I think that the nice thing about dupilumab is that we can do it at home. We can do it every 2 weeks. We can do it in our lab agnostic patients, and so, or our biomarker agnostic patients. So if we have a patient that doesn't have good labs, that makes me think omalizumab is going to be successful, I think that's a good choice. And they have comorbid atopic dermatitis or atopic conditions, then I really do think about that. For remibrutinib, it's I want relief now. I want it now, and I'm willing to take it, because you have to have good adherence to an oral medication. Remember, this is a twice a day medicine. I think that there's going to be growing data on chronic inducible, and there is data on angioedema. And so if they have those, I think that would be a choice for remibrutinib as well. And I think especially for our patients that have low IgE or that have that chronic urticaria index, or kind of our type 2B patients, or I'm using it a lot in my omalizumab failure patients. I think that they're a good group to kind of give a slightly different process. But I think that we're living in a time, and I'm going to talk quickly through this, where we're having new choices. So there's another BTK inhibitor that's in work, and that's rilzabrutinib, and it's in phase 3 trials, and it's going to be looking at patients who did or didn't respond to systemic therapies. And it's going to be 3 times a day. And their safety signals are similar to what we saw with remibrutinib. It's safe. They're going to be effective. And the dosing strategy is going to be a little bit challenging. I think that the 3 times a day is going to be a little bit more cumbersome. But they worked in urticaria and in chronic urticaria, chronic spontaneous urticaria, and inducible urticaria and angioedema. And they aren't seeing a lot of the immunologic concerns, which is nice. But I think we still need more data on patients with the BTK inhibitors. I think probably one of the biggest thing was an excitement after the ACAAI and the American Academy of Allergy, Asthma, and Immunology conference was the c-KIT inhibitors. And so there's 2 c-KIT inhibitors. So c-KIT inhibitors, c-KIT is a marker for survival for mast cells, and it binds to stem cell factor, and it's making sure that mast cells stay continuously around. And barzolvolimab was presented as far as a phase 2B trials, and they looked at it as an every 8-week injection, and they actually had about 62%, so similar to what we saw with omalizumab, as far as well controlled, so a UAS less than 7. But the interesting thing was that the response was as fast as the oral BTK inhibitors. It was fast, and it didn't matter their biologic response. But probably the coolest thing was that after they stopped it, they actually had some disease modification. And I think that that's where we need to be putting our emphasis, is how do we use medicines while they're on it, but then also when we stop it, how do we change the course? The adverse effects are something we're going to pay attention to for c-KIT inhibitors, because it did have taste changes. It had some asymptomatic neutropenia that was more mild, and it had some skin and hair changes. But it really is an exciting time to be taking care of patients with chronic urticaria. And in the works, there's biosimilars or different agents that are going to target IgE, or the Fc epsilon R1. There's an anticyclic 6 and an anticyclic 8, which are survival signals for mast cells and for eosinophils. There's agents targeting the MRGPRX2, which is a side chain on mast cells that actually have an induction of degranulation. And we're starting to look at our complement, our C5 receptor, as far as how we can do it. So in a lot of our patients that may not have type 1 or type 2B, that they actually may be more responsive to other therapies. And those are still in the clinical trials. I don't think that there's enough data to really help guide us through there. But I think it's never been a better time to actually practice in taking care of allergic skin diseases. So we can set us up for success. So the conclusions are chronic urticaria, it can cause a big quality of life impairment in our patients. We really need to make sure we're available and talking them through the choices. The diagnosis is clinical and it needs to be confirmed every time. Labs right now are not always the most beneficial, but they're starting to be. And I think that we are going to work on our biomarkers to make sure that we have the best choices. Antihistamines are our first step, and then we titrate up, and we now have biologic and systemic therapies. And all of them work, which is great. And so I'm happy to take any questions. I'm happy to answer everything to the best of my ability as far as everything goes.
Awesome. Thank you so much, Dr. Dunn, for that presentation and sharing your wisdom, of course, and your expertise on the latest CU treatments. We definitely have some questions, so let me get those. We have one question related to the scoring, the CSU scoring option. If you could please go over that once more, just to make sure that they understood it.
Gotcha. So the two major scores that we use are the Urticaria Activity Score, so the UAS, and then there's the Urticaria Control Test. So the UCT is probably used more clinically. I tend to use that because it's a little bit faster. It's looking backwards over the last month, their recollection of how much this is impairing quality of life. That score is from 0 to 16, and it's based off of 5 questions where you have 5 multiple choice and you kind of get to choose it on how bad this is bothering individuals. That one is a little bit more simplified because it does enable people to look retrospectively over a month, similar to what we think about from the like an asthma control test. The UAS, or the Urticaria Activity Score, that one is a little bit more day-to-day. So that one, you really have to think over a 1-week period, so over the last 7 days. That's why when we reference the UAS 7, we reference the last 7 days. And they take each individual day as its own entity. And they say, in this day, how many wheels did I have? So how many of the hives did I have from none to severe? And whenever they talk about it, they kind of rank it on a scale from 0 to 3, and then they take the itching score. So from 0 to 3 as far as severity of itch, and that gives them a single day score from 0 to 6. And then they do that for every single day and you add it together. That's how you get your UAS. And so your UAS score that's high is bad, whereas UCT low is bad.
So thank you. Thank you for that. We have a couple more questions. One is regarding managing expectations. You mentioned it in your presentation regarding some patients on omalizumab that may take months to fully respond versus weeks with the BTK inhibitors. The question is, how do you set expectations with your patients, and at what point do you decide that it's time to kind of switch gears?
So I always tell them when I expect them to respond, right? So whenever I decide a therapy, so if I'm going to pursue dupilumab, for instance, I always say, hey, which of these, things that you have going on are your top priorities? And I even have them rank it, right? So I have them say, my eczema, my atopic dermatitis is my number 1. And I'm like, great, okay. So if that's what we're thinking, these other 2 agents aren't going to touch this. But most of the time, if I'm really just thinking about chronic spontaneous urticaria, I'm then saying, great, so these are the choices. This one we're going to know fast, and I say for remibrutinib, I still set the expectation that I'm not going to fully know until 12 weeks. However, I may get some calls back, and you may call me in a week and say, oh my goodness, I am a responder, because a third of patients will know within the first week. The challenge with that is I tell them that they may see a response within the first 2 weeks, but you'll see maximal relief by that 12 weeks. For omalizumab, I always tell them very similar. I'm saying, look, we are committing to this for 12 weeks. We are committing ourselves to saying, hey, we're going to try this for 3 months. We may need to make adjustments. We may need to make adjustments for dosing, but in general, I kind of set that expectation. Because the first 3 injections have a prolonged wait, I do that in my clinic. And so I actually see them during that time, and I check in periodically during that time. A lot of my patients that are on it for chronic urticaria, I kind of have a suspicion within the first 1 to 2 months that we're starting to see that improvement in the first couple of weeks and then coming off. Even whenever I kind of lay out those choices, I always set the expectation. I say, great, we are going to be committing for 3 months for omalizumab and remibrutinib, and then 6 months for dupilumab. And I may know sooner, but I'm not going to know fully before then. And so I kind of set that expectation of, hey, we may have good days and we have bad days. I want to make sure that we look back over the 3 months to have that longer amount of data, because I don't want to get lost in the, I had a good day, I wasn't going to have hives anyways, and then I make a big change, or it was terrible. And I think there's some literature that's starting to look at, do you start one agent like remibrutinib that's going to know fast, and then if you don't have a response after 4 to 12 weeks, then to change? The urticaria guidelines really frown upon that. They say, just commit to 12 weeks, please, so that we actually have enough data to think through it.
Awesome. Thank you for that. There's another question. What would you suggest for someone that's with multiple autoimmunes, including thyroid, that are already taking 4 Zyrtec a day, but still having severe itching?
So remember with UAS, pruritus is one of the things that falls into that category. So that's kind of the nice thing about the UAS versus the UCT is itching is a dominant thing, not necessarily just seeing wheals. So I would offer them either, if they want to continue doing oral agents, you can do some of the leukotriene receptor antagonists like montelukast, and then talking to them about that. Or I would say that if you have multiple autoimmune conditions, I tend to, at least right now, I think that you could do either remibrutinib or omalizumab if you think that they're going to be a responder. I tend to have more success with one of those two. But it also depends on
Awesome.
what their autoimmune thyroid levels are, because that may change my decision tree.
Right. Okay. Awesome. We'll take one more question before we wrap up. For those more complex patients, like CSU with inducible triggers or angioedema, how are you thinking through treatment selection given the difference in data between these therapies?
Sorry, can you ask that one more time just to make sure I understood it?
For more complex patients like CSU with inducible triggers or angioedema, how are you thinking through treatment selection, given the differences in data between these therapies?
I think that it's the reason that we need head-to-head studies. I think that I'm gonna get up on my soapbox for 2 seconds, and it's gonna make it dangerous for everything. Is that I do think that we need better work on our biomarkers. I think that one of the things that we're realizing is a lot of this is retrospective data of looking backwards. We need prospective data. We need to say, hey, we've identified these biomarkers. We now are taking it forward and saying, great, we know that they didn't respond previously because of this, but now let's actually use that in clinical practice to predict it. I think that in our more complicated patients that have inducible urticaria or kind of have overlap with different phenotypes or endotypes. So phenotypes, right, that clinical description of inducible and spontaneous, and then our endotypes are lab findings. I have a preference that we need to have more head-to-head comparisons. There is a head-to-head comparison ongoing for remibrutinib versus dupilumab in a 4-week trial. Personally, I know that result is going to be that remibrutinib is probably going to work faster. And so but that's a guess. So I don't know. I'm hopeful that I'm going to be learning something clinically from that. And I love to be wrong, and I love to learn something new from it. I think that whenever I have somebody who has a lot of overlap, I have a tendency to not only address the cofactors that I can treat as far as how we keep them warm, for instance, if there's cofactor or their cofactor that's contributing is their temperature. But I also tend to lean more into our either BTK or IgE or anti-IgE to make sure that we're kind of treating them appropriately. I think you have more data for chronic inducible urticaria with omalizumab at this time, but there is not great head-to-head studies of this one versus that one. I think there probably is higher efficacy for omalizumab in that group where you have some blending. But it is still a big question. So clinically, I don't think that I have the greatest answer because I don't think we've done those studies, and that's a sad thing. I think we need to do those.
No worries. Thank you for answering that. This isn't necessarily a question, just wanting to try something as we end our webinars. What is one practical takeaway you'd like clinicians to apply to their very next patient with chronic urticaria?
I think that we need to listen to them and what their priorities are. I think we need to sit down and we need to say, hey, how can I actually help you? Right? Like I can give you medicines, we can talk you through it. We have the head knowledge of how we want to do it, but we actually need to sit down and say, what's your priorities? What is your biggest thing? And then also making sure that we're not overestimating it, not saying, great, you're under good control because you're on high dose antihistamines, but saying, hey, we do have these therapies. Is this the right time to pursue this and let them make the choice for their own health?
Awesome. Well, thank you so much, Dr. Dunn, for this presentation. We really hope that everyone has gained some valuable insight to take back to their own practice and managing their patients. In a few days, Zoom will email you a link to the recording as well as supplemental resources and a link to download your certificate of attendance. We hope that you join us next month for our webinar on eczema and other immune-related skin diseases and skin of color. On behalf of everyone at the Allergy and Asthma Network, we thank you for joining us today. We hope to see you next time and have a great afternoon. Thank you again, Dr. Dunn.
Thank you for having me.
Bye-bye.